so much.
We'll move on to Dr. Munier, who is joined now, and he'll be speaking to us on current status of management of vitreous and aqueous seeds. His discussant is Dr. Fairouz from Horus Eye Care, Bangalore.
Hello, everyone. Can you see my my screen?
Yes, yes, Francis.
Yeah. So, greetings from Switzerland. It's a great opportunity. Thank you, Santosh, for inviting me and being virtually with you in India. So, the synopsis of my lecture is as follows. I will start with what I consider the two most significant publications on vitreous and aqueous seeding in 2022. Next, I will talk all what you need to know about aqueous seeding and its successful management. And then I will end with our 10-year experience with intracameral chemotherapy in Lausanne. So the first paper of great interest, in my views, is the paper by the group of Paula Szajkiewicz, and she is addressing the problem of how to deal with refractory vitreous seeds. And she's offering a great hope with this preclinical study, basically saying at the end of the day that, you know, a dose, we can triple or even have 5 times the dose we used to inject in the vitreous, because this 100 microgram human equivalent dose is not damaging, is not toxic to the rabbit eye. So I think this will be translated into the clinic shortly, and this is a great step forward, I think. Future will tell, of course. Second paper of interest regarding aqueous seeding, and this is a paper from India. And I recommend you to go and read this paper from Swati Kaliki and Saumya Jakati. It's extremely interesting. They, in a large, very large series, they do a clinical pathologic correlation for aqueous seeding. You have to go and see this paper. Now I will focus for the rest of my talk. I will focus on aqueous seeding. As you know, aqueous seeding can be classified into primary or secondary seeding, depending if it's present at diagnosis or during the course of conservative management. Until recently, this feature of seeding in the intersegment was always going to enucleation. Now, what you have to know, and anyone who has to deal with aqueous seeding has to know that irrespective to the type, class of seeding, you know, cellular infiltration of the aqueous spheres or pseudo pseudo-hypopyon, you have to know that this is only the tip of the iceberg. And without knowing into more depth what is going on in the intersegment will not be enough to reach success management. So what I see as absolutely necessary is to equip the operating theater with, I have no interest, I declare that at the beginning, but to have an OCT, an anterior segment OCT in the OR, as well as an ultra biomicroscope at 50 megahertz. The importance of the OCT monitoring is to assess, there is now a way to assess with this tool, the Schlemm's canal. Because the Schlemm's canal is a vascular tissue, and if we can assess an invasion of the Schlemm's canal, I think it's a major risk factor for metastasis. So here is an example of such an eye with this in this section here, that there is an trabecular growth of a seed that anchored at the level of the trabecular meshwork, but also you can also note that there is a clear, I don't know if you can notice it, but there is a clear demarcation line indicating at least that there is no invasion of the trabecular meshwork, and moreover, the Schlemm's canal seems to be totally free. And we were able to correlate the findings in the OCT findings and histopathology with Alexandre Moulin, our pathologist, comparing these two sections here at 9 o'clock and 4 o'clock. As you can see, at the 9 o'clock position, there is also a growth not only on the iris but also on the trabecular meshwork, but still with this demarcation line, nice demarcation line, which is not disrupted. The Schlemm's canals also seems to be totally free, and this was confirmed by the histopathology. In contrast, the 4 o'clock section, there was a clear suspicion here of a trabecular meshwork invasion and occlusion invasion of the Schlemm's canal, which was confirmed by Alexandre when he reviewed the section of the enucleated eye. Second, your UBM is also critical to assess and to document the type of growth in the posterior chamber. You will see in a moment why I think it's important to do that. And of course, to assess if there is an intraciliary invasion or invasion of the iris. So this, by doing this, you have to have a good knowledge of the microanatomy of the fundus extremicus. And for those who are interested into more depth, I recommend to go and see this data published in my paper 2019. So the growth pattern, there are of several types in the posterior chamber. First, you can have a growth in the Hanover canal, the space between the zonule and the equator of the lens. Then you can have an invasion of the Petit's canal, so in front of the pars plana, and you see the anterior here. It's a transverse section here, and you can see they can be present as nodules, but as these nodules grow, they can be confluent, and they can create such plaques, you know, adherent without invading at that stage, without invading the pars plana, you know, and these plaques, they are adherent between the anterior and the pars plana. They are, in my view, a risk factor for relapse of aqueous seeding. Another type of growth in the posterior chamber is what I call the interciliary process implantation. I refer to actually seeds that anchor between the ciliary processes, and these seeds are continuously washed by the secretion of aqueous humor and therefore resistant because they are underexposed to the chemo injected in the anterior chamber, posterior chamber. So they also, when you observe this feature, it's also, in my views, a risk factor for relapse. Finally, you have what I call the posterior iris implantation. You see, without invading the iris, you have like a plaque anchored at the posterior face of the iris, and this is also a risk factor for relapse. Now, of course, you can assess also the anter-uvea involvement. Here, iris involvement, and here longitudinal and transverse section of an intraciliary body invasion. Now, the technique itself for the treatment was described in this paper, and basically it's a safety-enhanced injection to prevent, of course, the tumor spread, as we described for intravitreal injection. Now, it's an aqueous replacement technique. So we empty you will see in the video, and we replace the aqueous humor with a solution at a known concentration, typically 20 to 30 microgram per ml of either topical or melphalan. And this is to prevent the aqueous relapse that we do it in those chambers. And then we concomitantly inject in the vitreous, because one of the most frequent mechanism of migration is transyelloid, and we do intravitreal injection. Now, this is the video. Oh, sorry. I hope the video will work. Here, yeah. So I will comment. So it's a very long passage with a 34 gauge needle in the clear cornea. A long passage that is a 2-3 millimeter passage in the cornea. Then we indent both the eye and the cornea, and you will see that doing so, actually the cells behind, you see, this is the loop, the effect. We have cells passing from the posterior chamber to the antechamber. We have changed the syringe to now inject a little bit in the antechamber. You see all the cells that move from the posterior in the anterior. Then we perforate the roots of the iris. Because of the long passage, the stability of the needle is excellent. We never touch the lens. And we inject in the posterior chamber, and you will see how we can also bring material from the posterior chamber into the antechamber. I think this is critical to have a limited number of injection and to be as efficient as possible. Then, of course, you have to cryo the entry sites. And at the end, we complete the procedure, as I told you, with an intravitreal injections at 3.5 millimeter from the limbus. With a 34 gauge needle as well. And
the time is up.
Oh, sorry. So I finish with my 10-year experience, just touch briefly where we are. The study design was all patients with between December 2011 and 2021 with at least 1 year of follow-up. So this is the population of 20 patients. And the good news is that we have an overall eye preservation rate of 85%, with a mean survival follow-up of more than 4 years, and all metastatic free. Also, the vision was useful to near normal vision in 82% of the salvage cases. So at least we can say that intracameral is safe, is efficient to control seeding, and of course you have to add, as necessary, additional treatments to control the risk factors I mentioned, the interciliary process implantation, etc., or intraciliary invasion. And toxicity is limited and not side-threatening. I have no time to develop that. So thank you for your.
Thank you very much. Feroz, you are on for discussion.
Thank you, Dr. Munier. Hi.
Hi.
I take this opportunity to thank you for your valuable contribution and giving us the courage to go into the anterior chamber and go into the vitreous chamber with your introduction of the safety enhanced technique. And this has really made life easy for us and our patients. We all agree to that. So thank you once again, and thank you so much for this excellent talk and the demonstration of the video. So I have, I'm going to keep it really short because we are running out of time. A relevant question that I have for you is, Dr. Munier, regarding the prognosis and the way of treating the intracameral and the intraciliary and the interciliary seeds. I'm sure like the intra would be more difficult than the interciliary ones. Yeah. What is the outcome and prognosis in your series?
Yeah. Sorry, I have no time to develop that in details in a 12 minutes talk. But indeed, if you have let's say first, interciliary body implantation. This is a feature that is not so common, but in the 20 cases I mentioned, it was present in 4 of them. And to get rid of this tumor burden, because what is floating in the aqueous is easily controlled by the intracameral injection, but then you have a relapse from this part. And so the only way to control it is to put, in my views, a plaque in the meridians involved. And it's what we did successfully in all the 4 cases. Then for the intraciliary, similarly, it's also by brachytherapy that we have treated these. We attempted intra-arterial, but we were surprised to see that intra-arterial is not so efficient for intraciliary involvement. It was more efficient in the 9-3 o'clock position, maybe because of the long ciliary artery that are present in these meridians. But for the intraciliary component involvement that was at 6 or 12 o'clock, it was inefficient. So we had to put a plaque.
Okay.
Does it respond to your question?
Yes, definitely, Dr. Munier. One more question for you. So as far as the preference for the chemotherapeutic agent, topotecan versus melphalan, is there a preference that you have when you enter into the anterior chamber? Because, you know, it can cause uveitis, the corneal endothelium. We all know that melphalan is more toxic than topotecan. So do you have a preference in the chemotherapeutic agent when you go to the anterior chamber?
Yes, very good question. Actually, we have historically used more frequently melphalan, but I have to confess that we are switching to topotecan. It appears, of course, the series is very small, but it appears that we have more toxicity in the antechamber with the melphalan compared to topotecan. Especially cataracts that we observed in actually 60% of our injected cases, whereas it was only 20% of the cases injected by topotecan. Okay. But it's never linked to a lens touch of the needle, because the needle, remember, we have a long passage. We are actually in the Hanover Canal, or at least, you know, very peripheral, where the lens at the level of the equator of the lens, you cannot touch. If you have this direction of injection, you cannot touch the lens. No way.
Yeah, thank you very much. One last question. When you're going through towards the root of the iris, what is the chance of hyphema when you're injecting?
So we had in our series of 20 cases of spontaneous cases with 1 year follow-up, but we have more cases. We have 2 others that came up since that, and we have also a series of 5 cases with iatrogenic aqueous seeding. But in the total, so it's 27 cases, and we had only 1 case of self-limited hyphema. Okay, so it was only one case out of 27 that had we had just to press on the eye for a little while, and it was a self-limiting hemorrhage locally without hyphema.
Thank you so much for this valuable insight and sharing your data with us.
But I agree that, you know, you can have an associated rubeosis iridis, as you probably have observed when you have aqueous seeding. It can happen, and so you have to be very careful if it's there, because it's an additional risk for hemorrhage.
Thank you so much. Thank you so much, Dr. Munier.